Hi, everybody. I'd like to welcome you to this new webinar as part of the special series dedicated to the COVID-19 pandemic. And this webinar is going to be dedicated to issues related to clinical research, especially some aspects about the ethics of research in an emergency. We all know that the COVID-19 pandemic has stimulated a lot of clinical research. A couple of days ago, I could see almost 700 clinical trials registered with clinicaltrials.gov, and I'm sure there are more trials which are not yet registered. There are trials registered on different websites and so on. So this is really great news to, I think, having such an active clinical research activity, because obviously governments, institutions, and the public in general would expect from researchers, people like us, some credible data and reliable conclusions on which they can confidently, I would say, base momentous policy decisions about healthcare, but also economics and society. So, in another word, research integrity is really a crucial parameter despite being in a crisis. And we need really robust and evidence-based conclusions. And to discuss all this, it's my great privilege to welcome Professor Philippe Gabriel Steg, who is a professor of cardiology at the Paris Diderot University and also head of a cardiology unit at the Bichat Hospital here in Paris. He's also head of a research unit at INSERM. INSERM is a bit equivalent to IACH in the US. Also, and this is important to us, and I'm very grateful to all his efforts, he is member of the executive board of the so-called APHP, which is the Paris Hospital Network Assistance Publique des Hôpitaux de Paris, in charge of research. And he has been extremely active during this crisis about encouraging, facilitating, stimulating and driving, I would say, the research projects. He is a very famous cardiologist. I'm totally ignorant in cardiology, but I could see almost 1,000 peer-reviewed publications under his name recently on PubMed, and he had taken different leadership roles at the French Society of Cardiology, European Society of Cardiology, American College of Cardiology, and so on. His CV is around 100 pages. So Professor Steg, thank you very much for joining us for this webinar by the International Academy for Clinical Hematology. I'm very grateful that you accepted to give us your insights and your views, I would say, about the importance of ethics of research during this pandemic. And my first question would be about, just for our maybe younger audience, the basic ethical requirement. It's always good to remind all of us about the good practices in clinical research.
Thank you. Thanks for the very kind introduction. Thanks for inviting me. Let me start by a disclaimer. As you pointed out, I'm a cardiologist. I'm neither an oncologist nor an ethicist. I do have experience in clinical trials and observational studies, and that will color my presentation and discussion, and certainly many of the topics that I will touch upon are subject to debate, sometimes intense debate, and there is probably not a single right answer. There's a lot of perspectives that one can have regarding these issues. So I think it's appropriate to start with that kind of a disclaimer. Now, if we go back to the basics of ethics and good practice in clinical research, I think excuse me, I would list 4 basic ethical requirements that are the accepted ethics principles of clinical research. The first one is to recognize and respect the autonomy of the patient, which means that we absolutely must provide fair information to the patient, and we need to obtain an informed consent of the patient for any clinical study that we're going to do. And that is true also for patients in coma, in which there are procedures for obtaining emergency consent, next of kin consent, and this will vary from country to country, but I think the general idea that we must respect the autonomy of the patient is behind the need for information that's fair, comprehensive, and obtaining consent. The second point is that of beneficence, which is that we should try to do research to maximize benefits, and its benefits to society, to science, but also to the patient. And the third principle is the opposite, that we should have a principle of non-maleficence, that we should do no harm to the patient, and if there are risks related to research, we should do everything to minimize the risks. Now, I want to spend a little minute on this because there's often a tension, a dialectic tension between the principle of maximizing the benefits to science and society and what is perceived to be the individual benefit. And sometimes scientists may be tempted to violate the principle of non-maleficence because they think that expose a patient to suboptimal therapy, but that would be, quote unquote, for the greater good. And it is clear that the ethical principles that are part of most charters, the Helsinki Charter, the Nuremberg principles, and many charters that guide ethical principles in clinical research, absolutely exclude this. We should do no harm to the patient and do everything we can to minimize the risk to the participants. And another example that may be more relevant to many of our viewers who are oncologists is that there are diseases in which the uniformly dismal prognosis is often used to justify study of an experimental treatment. Think of recurrent glioblastoma, for instance. And there we should be aware that we should not subject patients to an unreasonably high risk with experimental therapy, even if there's a poor prognosis of a disease. And the final principle is justice, which means that we should have fairness in selecting participants. We should try to avoid selecting or focusing on vulnerable populations, such as prisoners, for instance, children, but we should also not exclude vulnerable populations, such as children or childbearing females. And there should be no selection based on race, gender, or nationality. Now, that also seems pretty straightforward until you think about what happens to patients that are excluded from trial. And oncologists, I'm sure, are quite familiar with the idea that many of these patients can get access to therapy in quote unquote compassionate use. And we have to be aware that there's an element of fairness that needs to be there as well. If you provide a new treatment for a serious condition on demand to patients who are not participants in the clinical trial, that is intrinsically unfair to those who agree to randomization. It could even bias the study results because there might be unknown factors that are associated with more vocal patients correlating with better or worse outcomes. And anything that biases the result of a clinical trial is inherently unacceptable because bad science is bad ethics. If another center is known to provide experimental therapy of study, the investigator should provide the patient with that information and assist with the referral for the therapy if the patient so desires. And if a patient demands an experimental therapy of study, the clinical investigator should not comply and explain the reasons to the patient and provide any available information on securing the treatment elsewhere. And that gets to maybe what would be my final point here, which is that bad science is bad ethics. I feel very strongly that there's a link between providing a good scientific answer and complying with ethical principles. There are often judgment calls in this, which is why that review by ethical boards and IRBs are of paramount importance, because they provide an external perspective from somebody who's not conflicted as an investigator in judging whether the procedures that are considered for research are fair and respect the four principles of autonomy, beneficence, non-maleficence, and justice. And I will conclude by pointing out an issue that is not black and white, but can be complicated, which is the issue of conflict of interest. So generally, investigators should not have a conflict of interest in a trial that they're participating in. They should not have intellectual property, for instance, in the therapy that they are testing. It seems pretty simple and straightforward, but you find out that there are issues where it is not as straightforward. For instance, we've come across rare diseases, sometimes extremely rare diseases, in which a scientist is both the recognized referral center and the physician that treats these patients, as well as the inventor of a therapy. And even though that physician may not be participating in a clinical trial, it's actually difficult to do the trial outside of his or her center. So sometimes these issues can be more complicated than it seems at first look. But these are the basics of ethics principles that should guide clinical research.
No, thank you very much. This is really very important, I think, and I believe in the clinical hematology community. One thing we are really very, I would say, familiar is this issue of first do no harm. However, I must admit that maybe in contrast, and as you highlighted nicely, to other fields of medicine, we are a bit like in hematology and oncology, a bit champions, I would say, of off-label use of many drugs, compassionate use, all of this under the umbrella of all the rules you have mentioned. But that brings me actually to the question we had always recently from different colleagues saying, well, hey guys, anyway, in a desperate situation, we are, you have a refractory acute leukemia. I mean, there is no approved drugs or whatever. Shouldn't we try something? So my question to you, are there any special rules or procedures for clinical research in case of a health emergency, as we are seeing with this COVID-19 pandemic?
I think that essentially the principles remain the same. And we should resist the temptation to forego rules because the situation is severe, either for the patient or generally for society as we're facing the COVID-19 epidemic. There needs to be proper methodology for studies. There needs to be ethical approval and consent. And these can be fast-tracked through accelerated procedures. We've been able to obtain review and approval of randomized trials within 48 hours. There are a number of additional issues that I want to allude to that are relevant, such as the fact that we're collecting personal data and biological material, including genetic material. And therefore, we need to be equipped for storage of this information while maintaining confidentiality. And in general, our infectious diseases colleagues drafted ahead of time protocols for studying pandemics during the Ebola and the chikungunya and the MERS-CoV epidemics that are quite useful now that COVID-19 has struck.
Yeah, so I think this is really very important message to the community that having a health emergency does not preclude that we have to follow the rules. And I think this is extremely important, and we have to do all efforts to accelerate the procedures, not to skip these rules. And I believe this is really very important message because we hear a lot about saying, well, you know, patients are dying everywhere, you know, what are you doing with all your procedure and so on. I believe, and this is very important to all of us and to everybody, is that these ethical requirements are mandatory, irrespective of the level of emergency. But then here, my question to you, and this is something we hear a lot in France, but in many other countries, about this very special, unique, privileged relationship between a patient and his physician. And that brings you to the freedom of practicing medicine. And the question is, how can we reconcile the needs for top quality clinical research, which will guide our indications, the prescription of drugs in a novel disease or novel complication? How can we reconcile this with this, you know, relationship between a physician telling you, well, hey, I know my patient, I have seen him, and I believe he should get this drug. Also, your drug is not approved, although I don't have evidence in general about efficacy, blah, blah, blah. So what would be your answer to this?
Oh, so that is the crux of, I think, a lot of the current debate that we're having, certainly in France, but not only in France, because I think it's become a worldwide debate. I think the example of hydroxychloroquine illustrates pretty well what we're talking about. So often people have the perception, and sometimes physicians themselves have the perception, that they have as perspective the best interest of the patient, whereas quote unquote scientists have the best the perspective of best science, and that there might be a conflict there. Let me try to debate this. First of all, I think that often in clinical research, what we have is clinician scientists, and certainly I count myself as one. I'm a trialist, but I'm a clinician. I care for patients on a daily basis, and I certainly care for my patients' best interests on an individual basis. Second, the opinion, sometimes the credences of physicians are not necessarily evidence-based, and sometimes they can be biased, they can be colored by our own prejudices, previous views, uncertainties, lack of knowledge, and we know that there's tremendous variability in care and management of many conditions, including severe conditions, that is not supported by evidence. And therefore, there can be tremendous variability, and we know that the standard of care with which many patients are treated can be found to be suboptimal or inferior to some experimental therapies. And finally, just as a footnote to this debate, I also would like to point out that patients who participate in clinical trials tend to have, it's well accepted that they tend to have superior outcomes compared to patients who are not participants. And there are generally two major reasons for this. The first one is that it reflects some selection bias of more severe patients with more severe comorbidities, older age tending to be excluded from clinical trials. But it also in part reflects more intensive and more frequent medical assessment and treatments of patients who participate in clinical trials, and therefore the indirect benefits of participating in clinical trials. A second issue that we need to discuss is the issue of controlled trials, and particularly placebo-controlled trials. And I mean, oncologists know better than I do that there is substantial disagreement as to when to use a placebo as opposed to an active control, and when is it justified. And there are a number of clinical scenarios where I think most everybody would agree that using a placebo can be important. For instance, there are diseases where the clinical status can fluctuate, in which it can be difficult to ascertain the effect of a treatment. There are conditions where there is a high placebo effect. There are conditions where there is no effective therapy, and therefore it's perfectly ethical to use a placebo, or where the only effective therapy is highly toxic. And again, I think that there could be judgment that it's acceptable. The concept that generally underlies the use of a placebo-controlled trial is that there must be some clinical equipoise between the alternative arms of a randomized trial. We should remember that in the clinical equipoise, we need to factor in the benefits of the experimental therapy, but also the possible unexpected harms from promising experimental therapies. And there's a long history of clinical trials in which a promising experimental therapy actually produced worse outcomes than the placebo arm. In cardiology, there are a number of famous examples, starting with the use of antiarrhythmic therapy to treat ventricular premature contractions in patients with acute myocardial infarction, where many physicians felt it was unethical to conduct the trial, and then to everybody's surprise, the trial demonstrated increased survival in the placebo arm and worse survival in the experimental arm, despite the fact that the arrhythmias were indeed cured by the antiarrhythmic therapy. Finally, I would point out that a control for a control arm is not necessarily a placebo, and it can be a standard of care if there's active therapy, particularly once more than one treatment becomes available for a condition, and particularly when the outcome is not survival, but progression of disease or other surrogates. Again, I'm talking to oncologists who probably are much more familiar than I am myself with this whole discussion. But I think defining the standard of care that is used in the control arm of a trial, whether it's placebo-controlled or not placebo-controlled, is a critical issue. And it goes back to the issue of proper information and consent, which means that we need to take the time to provide fair information to the patient, respecting the patient's autonomy. Now, let me put this in the context of the current debate. I think hydroxychloroquine and the debate about hydroxychloroquine illustrates what I feel very strongly here is that the core of our discussion. We have some in vitro evidence that hydroxychloroquine has some effect on viruses in vitro. In vivo, it's been tested several times in various viral respiratory infections, generally unsuccessfully. And in the latest iteration of clinical trials for treating chikungunya, it was found, to everybody's surprise, that the arm that got hydroxychloroquine actually had a worse outcome than the arm that got placebo. It worsened outcomes and there was toxicity from the treatment. Now, as I think everybody knows, there is some clinical evidence, probably of very low level, from improperly controlled non-randomized studies from France, that there might be some clinical benefit of hydroxychloroquine. But the problem is, because the trial was small and not randomized, it is far from definitive and therefore provides only controversial evidence. And I feel very strongly that getting as soon as possible to a proper assessment of benefits and risk of an experimental therapy is of paramount importance. And had the investigators done the exact same trial, but in a randomized fashion, we might be able to assess in a reliable manner today already whether hydroxychloroquine is beneficial, toxic, or neutral in treating COVID-19. Unfortunately, they didn't. And because they didn't, we're now left with tremendous uncertainty as to whether the benefits exceed the risks, which are very real. And as a cardiologist, I'm pretty familiar with that, with the fact that hydroxychloroquine can create torsade de pointe and severe ventricular arrhythmias, particularly if it's combined with azithromycin, which increases the risk, particularly in elderly patients who have cardiac pre-existing conditions, and if they have hypokalemia and hydroelectrolytes fluctuation, which is often the case in patients with COVID-19. And I think this is the best example I could find that doing a randomized clinical trial and getting quickly to the answer is actually the best way and the most ethical way to address the dilemmas that we're faced in finding treatments for emergency conditions such as pandemics or severe diseases.
Yeah, no, obviously the audience, as hematologists in general and people from the hematology community and myself, are not really top expert in this virology field and so on, but I can clearly hear from what you said. And again, I believe this is an important message to everybody in hematology, but also outside to everybody, is that the interest of the patient or the interest of science are not contradictory, and actually generating good science will serve the interest of the patients everywhere, and there is no such dichotomy. And then you alluded to the issue which we know very well about the different level of evidence or strengths of evidence in the clinical trials. We do have level 5, level 4, level 3, level 2, level 1, you know, and obviously some low-level evidence can generate some hypothesis in order to run these bigger trials. But this is, for me, if I want to summarize it from what I heard and just following like Mr. Everybody, it's about hope, hype, and reality. And we have to do the job in order to generate the good data that can be useful to the patient. But my role here is to continue to be the devil advocate, asking you, although it may not reflect my personal opinion, is, you know, I'm in front of a patient to whom I have explained, you know, everything about what you have nicely said. And I believe in Europe in general and outside the US, we didn't have this debate, but I know in different states in the US, there is this right to try concept. So in another word, I am in front of a patient and, you know, explaining everything. And then the patient is telling me, but, you know, I have the right to try. What should be my answer, you know, to this patient?
Yes, so I know I don't want to make it sound too simple, because I know it's not simple in practical terms and in clinical practice. And I know there's tremendous variation in perception across various geographies related to our culture, philosophic options, and even sometimes politics. So I'm sensitive to that. I do have an opinion. I am quite skeptical about the concept of the right to try. I think that the general guiding principle should be to respect the patient's autonomy. But to respect the patient's autonomy doesn't mean that we should contradict the principles of beneficence and non-maleficence, which means that in order to make a decision with the patient and to inform in a fair manner the patient about the research experiment, we need to have a reliable assessment of benefits and risks. And for instance, I think that if we go back to the example of hydroxychloroquine, I'm not sure that all the patients who participate in clinical studies understand that the risk of COVID-19, if you're an asymptomatic carrier or if you have modest symptoms, are quite modest. Actually, there's a 99% survival. Conversely, if you are with severe respiratory failure and you're being considered for mechanical ventilation, then of course your prognosis is much more grim. And depending on the situation and the setting you are, the acceptability of the risks related to an experimental therapy will be judged differently. The risks have to be proportional to the severity of prognosis. And therefore, an experimental therapy that would be perfectly acceptable for ICU or ventilated patients would not be acceptable in asymptomatic COVID carriers or outpatients, even as a compassionate or a right to try use. The second aspect gets to the issue of whether it's acceptable to test an experimental agent without a placebo control once its safety has been reasonably established. And I know this is often done in cancer trials. And I think, again, here we have these days a very good example of what's happening with the remdesivir single-arm study that's been reported recently that looked at the efficacy and safety of remdesivir compared to historical controls and claimed that this is a reasonably well-tolerated agent that appears to result in slightly improved outcomes compared to what we would expect in that population. However, because of the lack of a placebo control, we cannot reliably tell patients whether this is actually a true superior outcome or just some random variation in the severity of the patients who are enrolled. And therefore, I'm concerned that we may have a very unstable assessment and a non-robust assessment of the actual efficacy and risks of that experimental agent. And on top of it, having this data being in the public domain and widely publicized, and I'm sorry to say that I believe that this is in part for financial reasons related to the stock market rather than healthcare and the care of patients. This actually will jeopardize enrollment in placebo-controlled randomized trials, which should be done to reliably establish the validity of the claims of superior efficacy compared to the risks of that agent. And again, I think that when we have uncertainty, that decision is often best left to outside unconflicted bodies, which is why IRBs are so important in guiding our research, including non-controlled studies. I think it's good to have an external assessment of the ethics. If it's a research study, it could be an IRB. If it's a non-research study, I think consulting an ethicist is often a good judgment, good help to our judgment calls.
Well, that brings me, I think you have mentioned a keyword which is really all over the place these days with the COVID-19. It's about uncertainty, but also the complexity of all of what we're talking about. And actually, we as a scientific and medical community, for several decades now, we have established some, I would say, good rules that govern the robust, the peer-reviewed, and trustworthy research. And we have, I would say, well-established channels to communicate this. Obviously, it's never black and white, and there is a lot of scientific debate, which is actually something very good because it stimulates research and allows to continue the research. However, and I personally regret a lot that lots of the so-called scientific debate and discussion, which should have remained within the scientific community, are now going into the public field. And that brings me to the fact that whether we like it or not today, it looks like as researchers, as clinicians, as scientists, we have no choice also. We need to communicate our results, our work on social or other media, which are not the usual channels we use, like a peer-reviewed journal or an international conference with a moderator, and with a community debating. And I believe that we need a lot of professionalism, transparency, and it's not easy to bring to the public things that even the top experts sometimes, are hesitating or don't understand. So that brings me to the question, how, in your opinion, we can meet the expectations of the general public? People are entitled to know, and I believe even if you're not a scientist or a physician, you can still, understand what's happening. So how can we reconcile this? Because, we can't simply say, hey guys, this is just science, and we'll leave it to the medical journals, and we'll let you know when it's ready. So what's your view about this?
Yes, so you're making an outstanding point. We as a medical and scientific community need to step out of the ivory tower. There is no question about this. In the context of a pandemic that affects everybody's life, daily life, in such a dramatic manner as we've seen over the past few weeks, questions about medicine, science, and virology become everybody's questions. And they're no longer confined to medical journals and medical conferences. And we have to share the information in a fair manner with the public, accepting and acknowledging our uncertainties, our past mistakes, and sometimes. But I think it's really important to step into the domain of communication with the general public and not leave the quacks and politicians to make scientific decisions for ourselves. If we want to have input, we need to convince the public and explain to the public about what's happening, what is our best assessment of the situation. I think there are two types of communication. First of all, experts need to step up. I think the example in several countries of top leading experts participating into media communication and trying to communicate in an impassionate manner information to the public is really important. Dr. Fauci in the US is one such example. I also think that professional societies need to step up and in an unconflicted manner, not as individuals, but as professional societies, summarize and communicate in a transparent manner the evidence that we have and the lingering questions that we have. With the COVID-19 epidemic, we're seeing how much uncertainty there is. We are not sure of whether children are actually carrying the virus or actually are immune from the virus, and whether we should send them back to school or not. I mean, what we thought 2 weeks ago is very different from what we think today. And so I think that illustrates the need for the scientific and medical community to explain the uncertainty and sometimes the changes in opinion to the lay public. I think it's a moral duty we have. And if we do not do that, then we're leaving the field open for somebody else to step up and guide the public's feeling and decision and opinion. And sometimes that is not in the best interest. Sometimes it can be quacks. Sometimes it can be politicians. Sometimes it's politicians who happen to be quacks. So I don't think this is a good thing. I think we need to try to summarize the evidence, and we need to accept that there's also sometimes debate within the scientific community, and we're not unified as on many issues. Sometimes there will be a majority opinion and a minority opinion. I think it's important to communicate both. So it's not easy, but it's now become part of our job. In these dramatic circumstances, we cannot shy away from that duty.
Well, I believe we are reaching now the end of this webinar. That was really fascinating discussion. I personally learned a lot. I have enjoyed it. And I hope you would agree with me, and I will leave the last word to you in a couple of seconds, that my take-home message from our discussion is that uncertainty, complexity, emergency, all of this, it doesn't mean that we have to go away from ethics, transparency, integrity, and evidence-based conclusions. Would you agree?
Not only do I agree, I enthusiastically would support the idea that the most ethical thing to do in the context of an emergency with a severe disease is to get quickly to a reliable answer through reliable methods and ethical studies that are appropriately approved by the regulatory body. So I think that actually this is the most ethical thing to do, is to get quickly to a reliable answer. And we will be saving more lives by doing this than by doing poor studies that fail the ethical standards, fail our patients, and actually fail society.
Well, with this, I'd like to thank you very much, Professor Steg, for joining the International Academy for Clinical Hematology and to be our guest for this webinar. Thank you for all your efforts. I know you're doing a lot to help all of us in Paris and in France through your dynamic and active, and you have lots of energy in allowing to push forward this research, not in cardiology as you've been doing always, but now in this COVID-19 pandemic. So thank you all, and wherever you are, please enjoy your day, your evening, your night, or thank you very much.
Thank you for the invitation. It's been a pleasure.